Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones. 7th edition. Chapter 26. Infertility. Infertility nursing is a specialty, but general practice nurses also encounter couples who are seeking help or have had treatment for infertility in varied settings. A nurse may be a source of information to friends and family if they have challenges conceiving. Nurses working in the perioperative area may care for these couples during diagnostic or therapeutic surgery. Nurses in urology settings often see men who are being evaluated or treated for infertility. In the emergency department, nurses may care for women who are having a spontaneous pregnancy loss or a complication of an infertility procedure. Nurses in antepartum, intrapartum, and postpartum settings often encounter women with high-risk pregnancies or couples who have a new baby after infertility therapy. In addition, parenthood after infertility may be particularly challenging, and nurses in pediatric and psychosocial settings may counsel families about parenting and changes in their personal relationships. Extent of infertility. The extent of infertility depends on its definition. Infertility is not an absolute condition, but is a reduced ability to conceive. Infertility is defined as the inability to conceive after 1 year of unprotected intercourse, 6 months if the woman is older than 35 years of age, or the inability to carry a pregnancy to live birth. A more workable definition does not specify a time limit, but recognizes that infertility is any involuntary inability to conceive when desired. The definition is commonly expanded to include couples who conceive but repeatedly lose a pregnancy wastage, before the fetus is mature enough to survive. Couples with primary infertility have never conceived. Couples with secondary infertility may have conceived before but are unable to conceive again. 1 in 8 couples, or 12% of married women, have trouble getting pregnant or sustaining a pregnancy. This number may increase as women and couples intentionally delay childbearing. The National Survey of Family Growth reported that about 36% of married women and 9% of cohabitating women were involuntarily childless. Couples who delay childbearing until their mid to late 30s or later may feel pressured by the approaching end of their reproductive capacity. A woman without a male partner may seek infertility treatment before the end of her reproductive potential. For older couples, delay in achieving pregnancy or having a living baby may be more time sensitive than for younger couples, who, from an age perspective, have more time to pursue pregnancy and make treatment decisions. As new methods of diagnosis and treatment emerge, couples who once accepted childlessness may have new options for infertility therapy or resume therapy they previously abandoned. Factors contributing to infertility. Conception depends on the normal reproductive function of each partner. For some couples, identification and treatment of infertility are simple, but others require complex evaluation and treatment. Some couples delay childbearing until their mid to late 30s, when a natural decline in infertility begins. About 1/3 of infertility cases are male factor, 1/3 are female factor, and 1/3 are a combination of the two. Because some factors contributing to infertility remain unknown, treatment of an identified problem does not always result in a successful pregnancy. About 20% of infertile couples have no identified problem, yet some never conceive despite having undergone all available treatments. Male infertility factors. The test of a man's fertility is his ability to initiate pregnancy in a fertile woman. Few absolute criteria exist to distinguish normal from abnormal male fertility, although an adequate number of sperm having normal structure and function must be deposited near the woman's cervix. Problems may exist with the sperm itself, ability to achieve or maintain an erection, or ejaculation of semen or the seminal fluid that carries the sperm into the woman's reproductive tract. 1 or more findings may be abnormal, and further complicating evaluation of a man's fertility are the normal daily variations in semen. Abnormalities of the sperm. Evaluation of the semen via a semen analysis may reveal that the man has azoospermia, sperm absent in semen, or oligospermia, decreased sperm and semen. The average number of sperm released at ejaculation is 35 million to 200 million, but varies between 150 and 600 million in a typical ejaculate. 20 million sperm per milliliter of semen is considered the minimum number adequate for unassisted fertilization. Liquefaction of the semen occurs within approximately 20 to 30 minutes, allowing motile sperm to move into the uterus without the seminal fluid. A sufficient number of normal sperm must move in a purposeful direction to reach the ovum in the fallopian tube. Semen analysis is used to evaluate whether the quantities and qualities of sperm and the seminal fluid are likely to result in a successful conception, assuming that the woman's studies are normal. Abnormal sperm structure or movement may reduce fertility, regardless of the actual number of sperm. Inflammatory processes in the man's reproductive organs may cause the sperm to clump, inhibiting their motility and fertilizing ability. Other sperm have a normal appearance but may not be able to penetrate the ovum. Factors that can impair the number and function of the sperm include the following: abnormal hormonal stimulation of sperm production, acute or chronic illness such as mumps, cirrhosis, or renal failure, infections of the genital tract, anatomic abnormalities such as varicocele or obstruction of the ducts that carry sperm to the penis, exposure to toxins such as lead, pesticides, or other chemicals, therapeutic treatments such as antineoplastic drugs or radiation for cancer, excessive alcohol intake, use of illicit drugs such as marijuana or cocaine, an elevated scrotal temperature resulting from febrile illness, repeated use of saunas or hot tubs, or sitting for prolonged periods. Immunologic factors produced by the man against his own sperm, autoantibodies, or by the woman, causing the sperm to clump or be unable to penetrate the ovum. Abnormal erections. The inability to achieve or maintain an erection may reduce the man's ability to deposit sperm-bearing seminal fluid in the woman's upper vagina. Erections are influenced by physical and psychological factors. Central nervous system dysfunction, which may be caused by drugs, psychiatric disturbance, or chronic illness, can interfere with erections. Surgery and disorders affecting the spinal cord or the autonomic nervous system also may disrupt normal erectile function. Peripheral vascular diseases, from cardiovascular disease or diabetes, reduce the amount of blood entering the penis and thereby reduce the ability to maintain an erection. Drugs such as antihypertensives or antidepressants may reduce the erection or shorten its duration. Abnormal ejaculation. Abnormal ejaculation prevents deposition of the sperm in the upper vagina to achieve pregnancy. Retrograde ejaculation is the release of semen backward into the bladder rather than forward through the tip of the penis. Conditions that may cause retrograde ejaculation are diabetes, neurologic disorders, surgery that impairs function of the sympathetic nerves, and drugs such as antihypertensives and psychotropics. Men who have suffered spinal cord injury may retain the ability to ejaculate, depending on the level of cord damage. Anatomic abnormalities such as hypospadias, urethral opening on the underside of the penis, may cause deposition of semen near the vaginal outlet rather than near the cervix. Excessive alcohol intake or use of some therapeutic or illicit drugs can adversely affect ejaculation as well as sperm number and function. Ejaculation may be slow, absent, or retrograde when a man takes drugs that affect neurologic coordination of this event. Premature ejaculation is usually related to psychological disorders such as performance anxiety or unresolved relationship conflicts. Abnormalities of seminal fluid. Seminal fluid nourishes, protects, and carries sperm into the vagina until they enter the cervix. Only sperm enter the cervix. The seminal fluid remains in the vagina. Semen coagulates immediately after ejaculation but liquefies within 20 to 30 minutes, permitting forward progression of sperm. Seminal fluid that remains thick traps the sperm, impeding their movement into the cervix. The pH of seminal fluid is slightly alkaline to protect the sperm from the acidic secretions of the vagina. Adequate fructose, citric acid, and other nutrients must be present to provide energy for the sperm. The specific abnormality found in the seminal fluid suggests the cause of the abnormality, such as obstruction or infection in a specific area of the genital tract. Seminal fluid that is abnormal in amount, consistency, or chemical composition suggests obstruction, inflammation, or infection. The presence of large numbers of leukocytes suggests infection. Female infertility factors. A woman's fertility depends on the following: regular production of normal ova, an open path for her cervix through the uterus and fallopian tube to permit fertilization and movement of the embryo into the uterus for implantation, a uterine endometrium that supports the pregnancy after implantation. Disorders of ovulation. Normal ovulation depends on delicately timed and balanced hormonal interactions between the hypothalamus and pituitary gland, and on an ovarian response to cause maturation and release of an ovum. The hypothalamus secretes gonadotropin-releasing hormone, GnRH, beginning even before the obvious changes of puberty. GnRH stimulates the pituitary to release follicle-stimulating hormone, FSH, and luteinizing hormone, LH. FSH stimulates maturation of several follicles in the ovary. As the follicles mature, the ovary secretes estrogen to thicken the endometrium. About 24 to 36 hours before ovulation, a marked increase of LH level occurs, which stimulates final maturation and release of one ovum from its follicle. The other follicles regress permanently. The collapsed follicle from which the ovum was released, now called a corpus luteum, produces progesterone and estrogen, which further prepare the endometrium for implantation and nourishment of the fertilized ovum. Ovulation can be disrupted by many factors, including the following: a dysfunction in the hypothalamus or pituitary gland that alters the secretion of GnRH, FSH, and LH, failure of the ovaries to respond to FSH and LH stimulation, preventing maturation and release of the ovum. Disruption of hormone secretion or of the ovarian or endometrial responses to hormone secretion can be caused by many factors such as cranial tumors, stress, obesity, anorexia, systemic disease, and abnormalities in the ovaries or other endocrine glands. Women with polycystic ovarian syndrome often have challenges conceiving, in addition to other problems from abnormal hormone and ovarian function. 1% of women experience premature ovarian failure, POF, also known as early menopause, before the age of 40. Autoimmune disorders, genetic disorders, and family history may play a role in the development of POF. However, most cases do not have an identifiable cause. As a woman approaches the end of her reproductive life, also known as the climacteric, she ovulates and menstruates more erratically as her pool of ova diminishes and fewer are available for successful fertilization. This is called a decreased ovarian reserve. Oocytes are produced only during prenatal life and are vulnerable to cumulative toxic effects of therapeutic drugs, abused substances, and environmental agents. In addition to normal aging of oocytes and menstrual cycles, factors that may impair normal ovulation include cancer, chemotherapeutic agents, excessive alcohol intake, and cigarette smoking. Women with ovulation disorders often have abnormal menses because hormone levels do not permit normal development and shedding of the endometrium. The woman may have absent, scant, or heavy menstrual periods. However, other women may have no identifiable menstrual, ovarian, or hormonal disorders, and the inability to conceive may be their only complaint. Abnormalities of the fallopian tubes. At least one patent fallopian tube is required for natural conception and implantation to occur. Tubal obstruction may occur because of scarring and adhesions after reproductive tract infections. Infections such as chlamydia, gonorrhea, and other sexually transmissible diseases, STDs, are responsible for many cases of infertility from tubal obstruction. Prevention or prompt treatment and eradication of pelvic infections can reduce the incidence of fallopian tube damage. Endometriosis, uterine lining tissue growing and shedding outside the uterine cavity, may cause tubal adhesions, painful menstrual periods, and painful intercourse. Small lesions are unlikely to affect tubal function, but large lesions can distort tubal anatomy and lead to scarring, tubal occlusion, and subsequent infertility. Tubal obstruction may occur if adhesions develop after pelvic surgery, a ruptured appendix, peritonitis, or ovarian cysts. In addition, the fallopian tubes and other reproductive organs may have congenital structural anomalies that disrupt normal function. The conditions that cause obstruction may interfere with normal motility within the fallopian tube. Poor movement of the fimbriated distal end of the tube may prevent the ovum from being picked up at the ovarian surface after ovulation. Abnormal action of the cilia within the tube prevents normal transport of the ovum towards the uterine cavity. Depending on the extent and location of the blockage, fallopian tube obstructions can prevent fertilization of the ovum or lead to an increased risk for ectopic pregnancy. Complete tubal occlusion prevents fertilizing sperm from reaching the ovum, and the woman will be sterile or have a total inability to conceive without the use of advanced techniques such as in vitro fertilization. Partial obstruction may diminish fertility and may result in a tubal ectopic pregnancy because sperm can reach the ovum to fertilize it, but the embryo cannot reach the uterine cavity to implant. Abnormalities of the cervix. Estrogen levels from the ovary peak twice during the menstrual cycle, once before ovulation and again about 1 week after ovulation. The first peak occurs about 2 days after ovulation and causes the woman's cervix to dilate slightly and produce a clear, thin, slippery mucus that is similar to egg white in consistency, spin-barked. This mucus facilitates forward progression of sperm into the uterus and capacitation to prepare one sperm for fertilization. Low estrogen levels prevent development of this mucus and are usually associated with anovulation, menstrual cycles that occur irregularly without ovulation. Polyps or cervical os scarring from past surgical procedures such as cauterization or conization for cervical dysplasia may obstruct the woman's cervix. Abnormal cervical mucus caused by estrogen deficiency, surgical destruction of the mucus secreting glands, and cervical damage secondary to infection or other factors prevent normal capacitation and movement of the sperm through the cervix into the uterus and fallopian tubes for fertilization. Recurrent pregnancy loss. Early pregnancy loss is common. Approximately 20% of pregnancies may end in first trimester miscarriage. However, repeated losses may result from abnormalities in the chromosomes, fetal structure, placenta, or from maternal factors. Abnormalities of the fetal chromosomes. Errors in the fetal chromosomes may result in spontaneous abortion, usually in the first trimester. Chromosomal abnormalities often severely disrupt development, and the embryo or fetus does not survive. Maternal advanced stage associated chromosome abnormalities in the ova increase spontaneous abortions and decrease live births in older women who conceive. Most chromosome abnormalities are sporadic, occurring randomly. Others occur because one parent has a balanced chromosome translocation that is passed on to the offspring. The parent with the balanced translocation has a normal total amount of chromosome material, but the chromosome material is rearranged. When the chromosomes are divided during gametogenesis, development and maturation of sperm and ova, the resulting sperm or ovum may receive too much or too little chromosome material, or it may receive a balanced translocation like the parent. The sperm or ovum also may receive a normal chromosome complement with no translocation. Abnormalities of the cervix or uterus. Stenosis or congenital or structural malformations of the cervix or uterine cavity may cause repeated loss of normal embryo or fetus. These malformations may prevent normal implantation of the fertilized ovum or normal prenatal growth of the placenta or fetus. Others may increase the risk for miscarriage or birth before the fetus is viable. Women who were exposed prenatally to diethylstilbestrol, DES, prescribed to pregnant women in the early 1970s to prevent several pregnancy complications, were more likely to have uterine malformations or an incompetent cervix will not remain closed. Cervical or uterine abnormalities and possibly hysterectomy may result from trauma associated with a previous birth. Painless and premature cervical dilation and shortening, often early in the second trimester, is characteristic in women with an incompetent cervix. Although the woman may conceive, she may be unable to carry the pregnancy to viability. Uterine myomas, benign fibroid tumors of the uterus, and adhesions may cause repeated fetal losses if they occur within the uterine cavity. These problems can alter the blood supply to the developing fetus or cause uterine irritability that results in preterm labor and birth. Myomas on the outer surface of the uterus are often obvious but may not cause the complications that inner myomas may cause. Endocrine abnormalities. Inadequate progesterone secretion by the corpus luteum, luteal phase defect, prevents normal thickening of the endometrium for implantation and establishment of the placenta. The new embryo may not implant, or it may implant poorly. In other cases, the corpus luteum may develop and function properly, but the woman's endometrium may not respond to its progesterone secretion. Uncontrolled or untreated hypothyroidism and hyperthyroidism may be associated with the inability to conceive and recurrent pregnancy loss. Poorly controlled diabetes can result in repeated pregnancy loss and many other complications of pregnancy because of its effect on maternal blood glucose levels and the vascular system. Immunologic and thrombotic factors. Immunologic factors are implicated in some cases of recurrent pregnancy loss, although not all are established conclusively. The embryo has antigens different from those of the mother and ordinarily would be rejected like any other foreign tissue. However, the mother's body normally blocks this rejection response and tolerates the developing baby. Some women's bodies respond inappropriately to the embryo, rejecting it as any other foreign tissue. These women often have recurrent spontaneous abortions. Women with autoimmune disease, such as systemic lupus erythematosus, SLE, are more likely to experience fetal loss. Pregnancy loss in these women appears related to thrombosis or other damage in placental blood vessels. Women with SLE often have other complications during pregnancy, such as exacerbation of their symptoms, fetal heart block, non-reassuring fetal status on antepartum tests or labor monitoring, and fetal death. Women who have clotting disorders, either inherited or acquired, may be more susceptible to pregnancy loss resulting from thrombosis. These women may require anticoagulation in pregnancy. Some environmental agents have a well-established relationship to impairment of fertility and pregnancy loss. Others are believed to be damaging but do not show a conclusive link to pregnancy loss. In addition, the amount of exposure, dose, relates to the pregnancy outcome in most cases. Examples of established toxins are ionizing radiation, alcohol, and isotretinoin, Accutane. Suspected or known toxins are numerous. For example, cigarette smoke, anesthetic gas, chemicals such as organic solvents or pesticides, and lead and mercury in occupational settings. These agents may be directly toxic to the embryo or fetus, causing its death, or they may interfere with the normal placental function necessary to sustain the pregnancy. Infections. Infections of the reproductive tract are associated with general complications of pregnancy, and they also may be related to early pregnancy losses. These infections often are asymptomatic, making their diagnosis and link to pregnancy loss difficult to establish. Evaluation of infertility. Couples are often anxious for definitive therapy to achieve pregnancy, but a thorough assessment of their problems is essential for effective and financially sound treatment. Some tests, such as semen evaluation, must be repeated sequentially for an accurate picture. Even a targeted or focused evaluation is frustrating to many couples, especially those who are approaching advanced reproductive age. In addition, the usefulness and well-accepted normal values are not well established for some tests, and other diagnostic tests are investigational. Despite many examinations and tests, infertility may remain unexplained in couples who seek care. Women's healthcare providers and infertility specialists use histories, physical examinations, and diagnostic tests to identify the best course of treatment. The proposed treatments will consider the couple's ages, especially female, medical histories, physical examinations, and diagnostic testing. Therapy often requires a series of steps and procedures rather than one single treatment. The evaluation and care of infertile couples may involve numerous professionals, nurses, physicians specializing in reproductive medicine, gynecologists, genetic counselors, urologists, microsurgeons, embryologists, and ultrasonographers. In addition, general and specialized laboratory and radiologic facilities may provide diagnostic services. Nutrition counseling may be needed to support therapy. Because anxiety, depression, and relationship disorder are common in couples experiencing infertility, psychological counseling should be offered to help the couple deal with associated personal and family issues. Nurses working in infertility settings often coordinate communication among the many providers and help the couple negotiate the maze of evaluation and treatment. Preconception counseling. Couples may be offered preconception counseling to help evaluate the risk for autosomal recessive disorders and birth defects, and perhaps reduce the risk for bearing a child with an anomaly. Many women seeking infertility care are older than 35, an age at which having an infant with a chromosome defect increases. A thorough history and physical examination of both members of the couple, including their family histories, may identify increased risk for having a child with a single gene defect. Preconception counseling also can help the woman understand the importance of an adequate diet and avoidance of teratogens that can harm the developing fetus before she knows she is pregnant. History and physical examination. A thorough history and physical examination of each partner can help identify the appropriate diagnostic tests and therapy, and identify risk for birth defects in the couple's offspring. History. A reproductive history including the following is obtained for both the man and woman. The woman's menstrual pattern, including age of onset and menstrual characteristics, frequency, regularity, duration, amount of flow, presence of pain. Any pregnancies, complications, and their outcomes. Contraceptive methods, past and present. Previous fertility of the man or woman who with other partners. Pattern of intercourse in relation to the woman's cycles. Length of time the couple has had intercourse without using contraception. Exposure to potential toxins, including tobacco and illicit drug use. Prescribed and over-the-counter medications. Family history of multiple pregnancy losses, birth defects, or intellectual disability. Home tests the couple has used, such as over-the-counter ovulation predictor kits. Past surgeries, pelvic inflammatory disease, STDs, abnormal cervical cancer screening and treatment. Medical history, including childhood illnesses and surgery, and a history of exposure to toxins may give clues about the cause of infertility. The couple's past and present occupations may identify toxin exposure, stresses, or other adverse influences on reproduction. Investigation of their usual frequency and timing of intercourse may identify the need for a change to promote conception at the time of ovulation. Physical examination. Couples who seek help for infertility are often healthy. However, a thorough physical examination of each partner may identify endocrine disturbances, cranial tumors, or undiagnosed chronic disease. Examination of the reproductive organs may reveal structural defects, infections, cysts, or other anomalies. Chromosomal analysis or maternal blood clotting studies may be done for couples experiencing repeated pregnancy loss. Diagnostic tests. Each couple's evaluation is individualized, but based on the history and physical examinations, testing generally proceeds from tests that are simple, less invasive, and less expensive to more complex and expensive diagnostics. Simple evaluations can be done simultaneously. More complex tests are often delayed until their need is established. Early evaluation for the couple may include the following: ovulation monitoring kit to identify if ovulation has occurred, evaluation of the cervical mucus to identify changes that occur with ovulation, hormone evaluation such as estrogen, progesterone, LH, FSH, anti-Mullerian hormone, AMH, and thyroid function, ultrasound image of internal reproductive organs, radiographic imaging, hysterosalpingogram to visualize uterine cavity and patency of the fallopian tubes, semen analysis, testicular examination to include an ultrasound and or a biopsy, post-coital examination, therapies to facilitate pregnancy. Evaluation of the couple identifies whether therapy might improve their chances to conceive and complete a pregnancy. A variety of procedures may be used, depending on the couple's initial and ongoing evaluations and their personal choices. Some therapy is simple, such as timing intercourse to better coincide with ovulation. Other procedures may involve considerable expense, discomfort, or unpleasant side effects. Many infertile couples need a combination of treatments to improve their chances of conception. Identification of appropriate infertility therapy is not always straightforward. Many factors should be considered, including the couple's history, medical evaluations, financial resources, ages, and other time constraints, as well as religious and cultural values. Simple treatments are indicated before more complex ones, but the needs of each couple are considered individually. More aggressive diagnostic testing and therapy may be appropriate if the woman is approaching the end of her reproductive years, or if it is determined that conception is unlikely to occur spontaneously. Statistical success rates for various procedures often are difficult for couples to evaluate and vary widely among facilities. Factors that affect a center's success rate for a procedure are numerous. For example, a referral center that is willing to help couples with long-standing infertility may have lower success rates than one that accepts only couples with less severe problems. Pharmacologic management. Hormones and other medications may be given to either the man or the woman. Medication may be given to improve semen quality, induce ovulation, prepare the uterine endometrium, or support the pregnancy once it is established. Medications may be given to correct infections or endometriosis. Others may help men for whom erectile dysfunction, also known as impotence, or the consistent inability to achieve or maintain a sufficiently rigid penis, is the primary problem. Table 26.2 summarizes many of the medications used in infertility therapy. Medications to induce ovulation may be prescribed for the woman who does not ovulate or who ovulates erratically. Medications may be given to provide multiple ova if a woman plans to have intrauterine insemination, IUI, IVF, gamete intrafallopian transfer, GIFT, or tubal embryo transfer. Progesterone vaginal suppositories, or Clomid, is often used to stimulate follicle development. Human chorionic gonadotropin, HCG, can then be given to induce release of several ova. Human menopausal gonadotropin, HMG, may be injected in small regular pulses for pituitary insufficiency of LH and FSH, similar to use of an insulin pump. Ovulation induction, also known as superovulation, increases the risk for multiple births because several ova may be released and fertilized. A serious complication is ovarian hyperstimulation syndrome, which involves marked ovarian enlargement with exudation of fluid and protein into the woman's peritoneal and pleural cavities. Adjustment of medication dosage and serial ultrasound examinations to determine the number of mature follicles reduce the occurrence of high-order multifetal pregnancy, triplets or more, and ovarian hyperstimulation syndrome. Surgical procedures. Endoscopic procedures may be used to correct obstructions with minimal invasiveness in either the man or the woman. The woman may need a laparotomy to relieve pelvic adhesions and obstructions caused by endometriosis, infection, or previous surgical procedures. These cannot be corrected via laparoscopy. Laser surgical techniques may be used to reduce adhesions because they are minimally invasive, precise, less likely to cause new adhesions. Correction of a varicocele, an abnormal dilation or varicosity, by ligating or embolizing the dilated vein, may improve sperm quality and quantity, although there is not a consensus on its usefulness. Microsurgical techniques may be attempted for correction of obstructions in the fallopian tubes or male tubal structures. Transcervical balloon tuboplasty is a minimally invasive method to unblock the fallopian tubes. A thin catheter is threaded through the cervix and uterus into the fallopian tube. The balloon is then inflated to clear the blockage. Therapeutic insemination. Therapeutic insemination may use either the partner's semen or that of a donor to overcome a low or absent sperm count. Donor insemination also may be used if the woman's partner carries a genetic defect, or if a woman desires a biologic child without having a relationship with a male partner. IUI is a variation of therapeutic insemination that allows sperm to be placed directly into the uterus, thus bypassing the cervical mucus and reducing some immunologic incompatibilities. This process also removes many of the antibodies that interfere with sperm motility and ability to penetrate the ovum. Sperm for therapeutic insemination, or IUI, are obtained from semen collected by masturbation or donation. The sperm are washed in laboratory solutions to remove prostaglandins that cause uterine cramping and concentrated before insemination. Washing also removes many of the antibodies that interfere with sperm motility and ability to penetrate the ovum. If the man has retrograde ejaculation, he may take sodium bicarbonate 2 hours before obtaining the semen to render the urine alkaline. The urine is collected in a sterile container and washed with a medium to separate sperm from urine. Men who donate semen for insemination are screened to reduce the risk for transmitting diseases or genetic defects. They are questioned about their personal and family health history, including genetic disorders or birth defects. Questions about their social habits and personality can disclose high-risk behaviors and give recipient parents information about potential traits of their child. Physical and laboratory examinations are performed to evaluate the man's general health, determine his blood type and Rh factor, and screen for infections such as STDs or HIV. Carrier testing for specific genetic defects, such as sickle cell and Tay-Sachs diseases, reduces the risk for passing on these disorders. To reduce the risk for transmitting diseases that may not be apparent in initial screening, donor semen is frozen and held for 6 months before use. A man is retested for diseases such as HIV several times during the 6 months. Inadvertent consanguinity, blood relationship, can occur because half-siblings from two families may not know they were conceived with donor gametes. They may later conceive a child who shares a larger number of genes, both normal and abnormal, than the general population. For this reason, the number of sperm donations may be limited. Egg donation. Use of donor oocytes may be an option for some women who do not produce ova because of POF, who do not respond to ovarian stimulation, or whose ova are not successfully fertilized despite apparently normal semen. It is less successful if used for women who have a birth defect such as Turner syndrome, in which the ova regress early in life, or for women who have had radiation therapy to the pelvis. As in use of donor semen, egg donation carries the risk for infecting the recipient, the fetus, and possibly the male partner of the recipient. The egg donor is routinely screened for genetic problems that are more prevalent in her race and for hereditary problems that may exist in the donor or her first-degree relatives, parent, sibling, child. Other tests may be available before conception, such as chromosome analysis that may show fragile X carrier status or an abnormal arrangement of her chromosomes. Chromosome analysis may not indicate a problem in the woman who donates the egg, but it might increase the possibility of an abnormality in the conceptus.